Hi everyone, my name is Kowalski. I'm a CAMS ST5. I'm based at the Tavistock and Portman NHS Foundation Trust, which is North London. But last year I was a simulation fellow in South London and Maudsley Trust, so one of the mental health trusts in London. And they have a simulation centre now, which is one of the first mental health simulation centres in the country that's just specifically doing mental health simulation. And I'm presenting the course that I developed, which is around the mental-physical interface. That is where psychiatric and medical services meet, so generally in the general hospital in A&E, specifically looking at children and young people presenting in mental health crisis, but also who have physical health needs to their presentation. So I'll tell you a little bit about the background to the course and why it was developed, a little bit about the course itself, and also the findings that we've been doing so far. It's a course that I ran 10 times whilst I was in post, and it continues to run now. And we're also hoping to roll it out across London currently too. So, I don't know if there are any paediatricians in the audience, but they may be aware of this. Over a quarter of children attending general paediatric clinics have associated psychopathology, and this is mainly emotional disorders. So it's quite a heavy burden for those people who aren't necessarily in mental health services, but do see these children. And the prevalence of mental health problems found on children's ward is within the range of 20 to 35%. Sadly, CAMS services are somewhat stretched and under-resourced at the moment, so what we're seeing is that presentations to general hospitals are increasing in an acute setting. And this has an impact on, obviously, the way that that teams work with these children. But particularly the people who see them don't feel very confident in this area of working. It's not the main part of their training, paediatrics, emergency department. And the feeling is that they would benefit from some training to improve their confidence and their skills in managing these kind of cases. This is also part of the context is that liaison services for CAMS are very patchy. There's sort of different types of cover across the country. Some hospitals have liaison teams, some rely on the general community team to come the next day to see a child. So it's a bit complex and an area that really could benefit from a bit more working around interprofessional collaboration. So again, the context, we're seeing increasing prevalence of depression in young people. We're seeing increasing rates of self-harm. So this is only going to increase. And as teams are more stretched in the community, we're seeing a knock-on effect in hospitals. Fortunately for me, this has the Future in Mind report, which was the DOH report around CAMS services in the country, was published after I started developing this course. But thankfully, it does name basic training in all disciplines should include an understanding of the interface between physical and mental health, so what this course is about, and also that enhanced multi-professional training across this interface will be key to improving the experience of children and young people with physical and mental health problems. So it became quite a nice document that I could refer to when I was developing the course. So the team that I've been working with in the last year is Maudsley Simulation. So this is our website. We had a large grant from HESL, Health Education South London, to develop around 26 courses around mental health in a space of a financial year. So it was quite a big task. And to spread that across all of South London. So the mental health trusts of Oxley's, South West London and St George's and SLAM, but also the acute trusts too. So we've got a number of courses, and I won't go into them all, but if you are interested, there's a website you can look at. And this is the course that I'm presenting. So I guess the most important thing to say is that this was an interprofessional course, and I heard someone in a Q&A session that I just caught the end of it just now, talking about the need for everyone to learn together, because we tend to learn in silos, and this was very much the point of this course. What I wanted was for people who are all involved in these kind of presentations to come together to think about how they might approach the assessment and management of specific acute presentations of children with mental health needs, and also how they might work more effectively with their colleagues, so this idea of interprofessional collaboration when managing young people. So, logistical nightmare, but we managed it for the most part. The participants that came on this course were a mixture of people, so we can accommodate paediatric trainees from ST1 to 8, paediatric nurses bands 5 to 8, paediatric HCAs, which was a great group when they did come. They had a really interesting input to the whole course. Core trainees from psychiatry, higher trainees like myself, CAMS professionals, so people who see children in self-harm usually on a duty rota the next day, so they could be psychologists, psychotherapists, OTs, social workers. We also had some consultants come, both pediatric and psychiatric, which was great. And then we had people who also have a stake in this, who do see these children as well. So FYs, emergency medicine doctors, and GP VTSs. So quite a mixed bunch, which made it difficult in the debriefs at times, but I think was a really useful exercise for everyone. Just about the course itself. It's a one-day course, which was about, that's how we chose to run our courses, but it was also easier for people to be released for just one day. We had 12 participants, and on each day there was 3 clinical cases, but each case had 2 scenarios. And the scenario, usually the first one was about the point of presentation, and the second one was a sort of dilemma that happened later on when the child had been admitted to a pediatric ward. And we allowed 15 to 20 minutes per scenario, and we had 2 participants per scenario. And it was a bit complicated in terms of how we ran things, because we had varying levels of sort of seniority. And so the way I chose to design the course was that we have one person of a more junior rank going in to do the first part of an assessment or to try and deal with a problem, and then having the second person, who was more senior, actually in another room, not aware of what was going to come their way. So sort of trying to replicate you on call and you're being called and you don't know what's on the end of the phone. And then that person would have the first person would have a discussion with the more senior member of staff, and then they'd go back together to the patient or the relative to discuss what was going to happen. So the idea was to sort of replicate normal working patterns, but where possible, I tried to include people from different disciplines as the 2 participants, so that it was two specialties talking to each other, which was all about the sort of shared decision-making aspects of the course. And obviously the scenario learning was shared by all. Participants would watch the scenarios happening in the debrief room. So these were the scenarios themselves. We had assessment and management of acute anorexia nervosa, and then this child later on wanting to be discharged, and the parent also wanting to discharge them, but in the context of severe physical needs that would need to be treated as an emergency. We had assessment and management of acute psychosis, which was possibly an organic cause, but it wasn't clear whether it's a first presentation psychosis or something more organic in nature. And this child subsequently having acute agitation on the ward and requiring rapid tranquilization. We had assessment and management of deliberate self-harm and overdose, and then later on this child disclosing sexual abuse on the ward and thinking about what to do in those kind of contexts. So, I mean, this is a simulation conference, so you know that simulation is experiential and reflective. Interprofessional was really important for some of the learning outcomes, and we did use a structured debrief, which I'll tell you about in a bit. This is Ben, who played our young man who presented with deliberate self-harm. He's actually older than 15. He was supposed to be 15. He's about 23, but he just looked very young. This is the model we use, the KHP model of DAA. It's sometimes called the Diamond Debrief model. It's designed to really try and draw out some of the non-technical skills in the analysis. But as this course developed, it started to be used to draw out sort of more of the competencies to do with collaboration, interprofessional collaboration, which I'll go on to talk about. And then the application phase is really key for me. Actually, it's all great doing a lot of talking, and as a psychiatrist, obviously I love that. But application was really important. Actually, what are we going to do from here, and how can we make practice better? I don't know, you'll all be aware of a lot of the non-technical skills, so I'm not going to go into these too much, but these are some of the things that we talked about that came out. Particularly this umbrella, if you like, of care and compassion, I think is really important, certainly in the case of mental health of people with mental health needs, because anecdotally you see it's an attitudinal an attitude towards patients presenting in this way, and sometimes they can be very challenging patients and very difficult. And part of the course for me was to try and sort of alter attitudes towards this demographic to help promote understanding of their needs. Here's a debrief, so there's everyone around the room. And this is the demographics that we had in the initial pilots. This was 10 courses. We had 99 people. And as you can see, it's quite a spread. The majority did come from peds, actually. Most of this is sort of peds here, which is great. And we had some GP VTSs. And then these are the psychiatry trainees, the CAMS professionals, and the 3 consultants. Other was the FYs and the emergency medicine trainees. So measurement, it's quite tricky. I'm now out of post, so the longitudinal measurement is kind of continuing with the team there, but it's not as cohesive as I'd like. But at the time, we were doing a lot of sort of reactionary and sort of immediate feedback, which is kind of common on these courses. So we used a lot of free text answers on our questionnaires, and I did focus groups later on to sort of really try and explore what they were getting from the course. We did pre- and post-course Likert scales in confidence and attitudes. So those were lots of different domains that we broke down. And we did show statistically significant improvements in confidence in general in managing and assessing patients. And we showed an improvement in attitudes towards patients. And crucially as well, perhaps, attitudes towards roles and responsibilities in the care of individuals. So that's nice that people sort of started recognizing that it was their responsibility to engage on some level with this case, to try and take a history, to try and be empathic. So here is our quantitative data. I'm not a massive fan of quantitative data in educational research, but you can see the domains we were trying to hit. We've got good effect sizes, and all of them were statistically significant. So we showed that people were learning lots of different aspects. And the thing with a course like this is people have lots of different deficits in what they need to learn. So it was hard to kind of capture everything. And same with attitudes. So attitudes less successful because they're harder to measure as well. So some of these are not statistically significant. But the two that have moderate sort of effect sizes is this roles and responsibilities. And then interestingly, dealing with behavioral difficulties. So the attitudes towards that it wasn't a child just being difficult or attention seeking. It was actually that this child had was severely distressed and in need and in pain. The qualitative data, so lots of different domains here that we picked up. Simulation in general, I mean, I think most of the people who run simulation will find that a lot of people enjoy the experience, that they find this, in particular for this course, it was realistic. It's quite hard to get realism in mental health simulation. It's very contingent on the actors, and we spent a lot of time with them to try and get it right, the accent of reality right. Those scenarios felt relevant to everyone, which was key for me. There's good breadth. They liked the opportunity to practice, and again, the interprofessional nature was really commented on. Lots of different knowledge competencies that were picked up, things about roles and functions of other teams. Some people in the room had never met each other. You know, they'd never seen a CAMHS clinician, for example, or we were some sort of mythical entity that just appeared and then disappeared. So it was quite nice to debunk some myths. The management and assessment of psychiatric presentations key. Guidelines, lots of guidelines were talked about in sort of the clinical parts of the debriefs. So we talked about restraint and holding of children. We talked about rapid tranquilization, about what to do in sexual abuse allegations. And this was also important, talking about sort of escalation, referral, and where to access support. So it was about just the hospital policies, really, and who was in place that you could get support from, either hospital managers or the lawyers, that sort of thing. And as with usual, with mental health teaching in general, a lot of people need to feel a bit more comfortable with the legal frameworks that we use. So that was also part of the learning. Technical skills, it's hard to sort of talk about technical skills in mental health, but there are sort of things such as assessment tools that we use, and sort of specific things that we would class as technical skills, so things that you can actually do that should make a difference to your history or your engagement. And there's tools that people talked about a lot. PEDS was the HEADS tool, which is a way of sort of remembering the things you should ask about drugs and alcohol, about home. So people learned about that. They learned about SBAR. Lots of different things. And we had to be quite flexible in the debriefs of what came up and just go with that, really. Communication came up, about improved communication, but also about thinking about and reflecting on your own style of communication with people, but also with each other, with other teams. And this is quite nice. I learned some methods to validate young people's feelings, to problem solve with them, which is actually quite a clinical skill in itself from a psychiatric point of view. Teamwork. So lots of people talked about how it developed their confidence to manage stressful situations within multidisciplinary teams, being more aware of the CAMHS team and their role to help us, communication with PEDS during the assessment, so stuff like that. This is nice. Attitudes. CAMHS people are people too. That's my favorite. As opposed to monsters. Be more open when approaching children and young people with mental health problems. That's very nice to hear. Awareness of stresses and looked after children, and be more understanding with their challenging behavior, which links to the statistical stuff we got. This, for me, really became kind of a key aspect of looking at the course. And I don't know if people are aware of the sort of interprofessional competency frameworks that are available, and this is quite a good way to look at interprofessional teaching in a way. And I chose this one, which is from the University of Curtin. It's the Interprofessional Capabilities Framework. And there's some overarching, tenets, if you like, and then there's these 5 domains of what constitutes effective interprofessional collaboration. And so using that as a lens to look at the data we got, we did see that a lot of what was being talked about, particularly in the focus groups, was demonstrating that people were achieving these capabilities. Or at least they were being more aware of them. So the idea of team functioning, people talked about involving colleagues earlier, seeking advice more. There was a recognition of the importance of shared decision-making and common goals. And this is also key. Sometimes a problem for mental health services is the respect for the contribution of all team members to this process, that we're all in it together and that we all provide something unique that can be helpful when it's all put together, if you like. Reflection was important. There was a space to reflect on own clinical practice, but also an improved appreciation of professionals' perspectives, better awareness of teams' roles and responsibilities. We've talked about that. Intention to better hand over information, to discuss cases more. And this conflict resolution, I think, is really key, especially when we're working across boundaries. This idea of exploring conflicts, and we were talking about hierarchy just now, it's hard to get to in the debriefs. We rarely got there, actually. It required a lot of courage for people to talk about this stuff, but we sometimes did really touch on it, especially with the HCAs, which was fantastic. Acknowledgement of the innate potential for conflicts to occur, as well as the potential values for these. And some people talked about having strategies to overcome conflicts. So what are we doing now? I think, it's still running, and I want to improve the quality to really make sure that what we're doing is actually what we're saying we're doing. And that's going to be part of the longitudinal measurement of the educational impact. Improving the fidelity of the scenarios, working with the actors more. Trying to improve the efficacy of the debriefs as well, particularly to draw out some of the interprofessional collaborative stuff and this stuff about hierarchy. Improving measurement. I'm in discussions now with the London School of Paediatrics about rolling this course out across London in various sim centres, so I'm very pleased to be here, because I think it's really got a great opportunity to be rolled out further afield and to really be useful elsewhere. Disseminating my findings, so obviously I'm here, and sustainability is tricky. We've got teams still in place, and people are delivering the course not as we speak, but I think there's one this month, so that's great. Just to leave you very briefly with a couple of quotes. It's highlighted the importance of working together as a team to get to the common goal of treating that patient, and actually realizing the only way you're going to get there is if you do it together rather than doing it separately. And when you have that attitude or a difficult scenario, just remember that they are vulnerable children and that they are probably in pain. And that's me. Thank you.